Hi everyone, it's Dr. Ray Goh here from Valley Plastic Surgery and thank you very much for joining me tonight on the Facebook Live. We're going to be talking about rhinoplasty and a few of the in-office type procedures that's in trend at the moment, including direct brow lifts and lip lifts as well. I have a few questions here and okay, so just reading the messages that are coming across. Okay, yep. All right, so I'll give people a bit of a chance to join the Facebook Live, and then I'll start talking, otherwise people may miss out on valuable information. So I have a few questions here that have been submitted by people in regards to rhinoplasty, as well as brow lifts and lip lifts. So if you do have any questions, please don't hesitate to submit it. I can see Narelle Sunderland, hi. If you have any questions, please submit them and I'll try my best to answer all questions that you might have relating to rhinoplasty or any other plastic surgical procedures. Okay, so we're on. I have a few questions here and I'll just go through them. The first one, someone has asked, is rhinoplasty ever covered by Medicare? What if you have a deviated septum or breathing issue? Also, if it is covered, how much does it bring the whole cost down to? Can you also change the shape of your nose when you're fixing the functional issues and still have the whole procedure covered by Medicare? Well, there are item numbers, Medicare item numbers that's applicable to the nose. These item numbers include rhinoplasty, septoplasty, and turbinate reduction. And there's various different item numbers with different descriptions for the surgical procedure. There are qualifying factors that's required in our assessment of a patient's nose to be able to use those item numbers. And those item numbers do invite support from Medicare as well as your private health insurance. So the main two qualifying factors are breathing issues, and with every nose consultation I will provide a nose survey that you fill out, and the numbers have to add up to be sure that you do in fact have a breathing issue or a congenital or trauma-inflicted deformity to the nose. I, as a nose surgeon, as a rhinoplasty surgeon, consider both the functional as well as the cosmetic components of a patient's nose at all time with every nose, with every patient. I think gone are the days when you get a functional nose surgeon and a cosmetic nose surgeon together in the same operation to fix up the individual aspects of the nose. I think if you're a nose surgeon, you're a nose surgeon. You should be able to fix both the cosmetic as well as the breathing issues at the same time. Sure, there are certain things such as sinus issues or things further deeper in the nose that maybe an ENT surgeon may need to deal with, but in general, most functional issues pertaining to breathing can be fixed by both plastic surgeons and ENT surgeons who are fluent with rhinoplasty. So yes, you can attract Medicare or private health insurance support, but with most surgeons, it doesn't cover the entire cost of the surgery. Where it really helps out is in the hospital admission, whether it be the day surgery center or the private hospital admission if you're having an overnight stay for a much more extensive rhinoplasty. That's where it really helps out, because that can be anything from $4,000 to $5,000 to $6,000 in savings if your private health insurance helps you out with the rhinoplasty. Now, somebody asked, what if you're dealing with the cosmetic aspects as well as the functional aspects? Well, I consider all that together as one procedure, septorhinoplasty or rhinoplasty. If I'm going to correct the functional aspects, I will also correct the cosmetic aspects at the same time, and the item numbers will still apply. So hopefully that will help clarify that question, in that Medicare and private health insurance do help out if you have a breathing issue related to your nose, or if you have an obvious deformity such as a deviated nose or a crooked nose, whether that be congenital, you're born with it, or whether it be post-trauma. And I always consider a rhinoplasty or a septal rhinoplasty fixing the functional as well as the cosmetic issue all at the same time. And I think these days, if you're a fluent rhinoplasty surgeon, you should be able to address both. Does anybody have any questions in relation to Medicare or private health insurance help with rhinoplasty? If not, I'll move on to the next question. Someone has asked, do you do non-surgical rhinoplasty, and what are non-surgical rhinoplasties? How much does it cost? Is it permanent? Okay. I only do surgical rhinoplasty. I do know of some colleagues of mine who do non-surgical rhinoplasty. So what is non-surgical? How do you have a rhinoplasty without surgery? When people talk about non-surgical rhinoplasty, they're mostly talking about fillers. Fillers are more of a camouflage technique. So if you have a bump on your nose, you can fill the area above the bump to make the bump look a little bit smaller. Or if you have some irregularities on your nose, you can fill up those contour depressions to make the nose a little bit even. But you will still have that bump there. How long do fillers last in the nose? Well, it depends on what type of fillers you use. They usually last for quite a while, and sometimes the effects can be almost semi-permanent. I would never recommend someone use a permanent filler straight up. I would actually suggest that they use a semi-permanent or temporary filler to see what the results are like and to top it up if necessary. There's a question that's come in. Who do you think is the best health fund? Well, I know who the worst health fund is. I'm not sure if I'm allowed to say. NIB is pretty bad. I think most of the health funds, in terms of how much they cover, is approximately the same. I don't think there is a best health fund, because sometimes one health fund may give better rebates for a particular procedure, but not as good with another procedure. I don't have any personal preferences for which health fund is the best. I'm with Medibank Private. That's mostly for maternity, which I don't use, but it's for my family. But any of the smaller health funds are good as well. Just keep in mind that the health funds mostly cover they'll give you rebates for the surgical fees and the anesthetic fees, but where they really come into play is the hospital fee, which is about the same for all health funds. They all cover the hospital fees minus the excess. So if you have an excess of 500, you pay that much. When you have your hospital admission, you have an excess of 250, you pay that much. If you have no excess because you're a very high level of cover, then you have no excess when you go into hospital. So I don't think there is a best health fund. I think you really have to think about what your health is like, what you need. If you don't need obstetrics care, then you probably don't need a health fund that covers that. There is no best health fund for plastic surgery. Hello, Bree Grace. Thanks very much for joining us. Would filler help with a bulbous nose? Could it help sharpen the tip? I don't think so. A bulbous tip. So this is what a bulbous tip is. You have two cartilages that come out at the tip that form your tip complex. A bulbous tip usually means that those cartilages are large, they're too long, or they're unsupported. So there's a lack of support, which means that those two cartilages just sort of flop out, and you can get a boxy or a round or a bulbous tip. Sure, fillers can maybe right at the tip can just give it a little bit more pointiness, but you're still going to have the bulbosity there. So I think in general, you cannot fix a bulbous tip with fillers. What bulbous tips need is actually tip support and refinement. You actually need to bring those cartilages here together, and you need something in between it to keep it there. Because if you just bring things together, over time, it'll become loose again. But if you bring it together and support it onto a graft, like a cartilage graft, it usually will stay there. Consider it like a tent pole with the canvas over the top. If you don't have a strong tent pole, the canvas is just going to be very floppy, and that's just like a bulbous tip. So I don't think fillers are great for bulbous tip. I think they're good if you have a small hump in the bridge and you can fill up above it and maybe below it to camouflage it a little bit. But a truly bulbous tip, I don't think is a great solution with fillers. I hope that answers your question, Brie. Question, any health fund that sends patient overseas for surgery? That's not a question, is it? Any health funds that you send patients overseas for surgery is questionable. I think so. I think health funds should not send patients overseas, and this is purely from a safety perspective, because all surgeries, whether it be plastic surgery or any other kind of surgery, carries risks. Complications don't happen commonly, but if they do, you want to be in the best care, close to home, where you know you're going to be looked after, because that's what health is about still. Every surgery is still a medical procedure that carries its risks. If you're having stuff done overseas, great, the procedure may work out perfectly and everything may go smoothly, but if you have a complication, what's going to happen? Do you then go back overseas to have that looked at, or do you go to the emergency department here? It's just a lot harder when that happens. And I get a lot of patients who come to see me and they say, oh, they've considered having surgery overseas, but then when they weighed up the pros and cons, they thought they feel safer to have the surgeries done here, where they know that they're going to be in the best care and best hands. And if for some unforeseeable reason, complication may occur, that they know that things are going to be looked after, that they're still going to get the best outcome, and that their lives are not at risk, and they're in good care. Okay. Any questions in relation to fillers and rhinoplasty or health funds? Okay, here's a good question someone's asked. How long does bruising and swelling last after rhinoplasty, and what's the downtime? Okay, so I will usually say, what do patients mean by downtime? I think in general, people, when they say downtime in relation to surgery, means how much time do they need off work? Again, that depends on what sort of work you do. Are you a school teacher? Are you a policewoman? Do you work as a laborer? Do you work in the office? For rhinoplasty, this is the course post-operative. I think it's better for me to explain to you what happens after the operation before I say what the downtime is like, so that you understand what's involved. So after you've had your operation, you go home, we give you a phone call the next day to check on how you are. You usually have a splint on the outside and a couple of splints on the inside, especially if we're doing some septal work or harvesting some grafts. Then you have about 4 stitches on the outside, and the rest of the stitches are inside the nose. You go home, you come back a week after to take the splints off, the splints out, and the stitches out. You'll be very swollen at that 1 week point. That's when I start taping the nose with an elastic tape, and I teach you how to do that. And I teach your family members or partners or close friends how to do it for you. And that's very important in terms of controlling swelling. Taping is one of the most important things. And I personally, if I can, will teach a patient how to do that. Then the patient comes back to see me, usually around weeks 2 to 3 weeks in general. And that's why I bring them back at that time to make sure that they're taping the nose properly, and that the swelling and the internal scarring and the way the nose is healing is in the right direction. If you just have your nose job and come back in 6 months, what's going to happen during that period? I need to see and know that everything's healing in the right direction, because there are things to do, homework, that both surgeon and patient needs to do to encourage the nose to heal it in the right direction. And a lot of that is swelling control, internal scar control. By about week 3, when patients come back and see me, they're already back at work, especially if you're an office type worker. You can go back to work usually by about week 2. You'll still have some swelling. You might still need to tape the nose at night when you're at home, but you're usually back at work after 2 weeks. Your nose may be a little bit stuffy still, but you're usually back at work, especially if it's non-laborious work. In terms of exercise and heavy lifting, that kind of work, I'd say 4 to 6 weeks, which is equivalent to most surgeries in general. But in terms of downtime, I'd say it's usually 2 weeks before you can go back to work if it's a light work. Bruising and swelling is related to a great extent to the patient's skin. And that's one thing that I'll take note of as soon as the patient walks through the door is I'll have a look at the skin. Thin skin versus thick skin. Advantages and disadvantages to both. If you have thin skin, your swelling and your bruising will go down a lot quicker. However, with thin skin, everything underneath the skin can be visible. So if there's any contour irregularities, that's going to be visible. So it's really important in thin skin patients to get everything perfectly smooth. And kind of what you get on the table, operating table, is what you're going to get post-operative 6 months, 1 year down the track. Whereas with thick skin patients, it's like having a beautiful sculpture. Like, for example, if I had this, and then I put a silk scarf over it, I can see every nook and crevice on your skull. Whereas if I put a big down jacket over this, I can't see a thing underneath it because it's so thick. Same thing is with thick skin noses. If it's very thick skin, I will expect a bit more swelling and a little bit more internal scarring, and the swelling and bruising and scarring will take a little bit longer to dissipate. And we tend to want to sort of overdo things a little bit because we know that there's going to be a bit of scar buildup because of that thick skin. I hope that makes sense. So in thick skin individuals, the bruising, the swelling, internal scarring tends to take a little bit longer to dissipate and tends to be a little bit more internal scarring as well. There's a question that's come up. I've had a rhinoplasty that I think, like you said, has collapsed. So if I need a revision, is it a longer surgery with longer recovery? Heard you do a lot of revision. So is recovery longer because of scar tissue problems? I'd say in general, the answer to that question is yes. Revision rhinoplasties are tough. The nose is a small space, and I saw a few patients today for revision rhinoplasties, and it surprises me how collapsed some noses are. Like if I press them on the nose, like I've got quite a bouncy nose there, but a few patients that I saw today, I press and the whole nose just flattens to their face. And they've had previous septoplasties, previous rhinoplasties, and everything's gone. Septum's gone. Someone's taken some ear to try to put in there to build it up. That's collapsed as well. The bone's asymmetrical. Everything's fallen down. That's going to take a hell of a lot of work to fix up. And that will often require a rib cartilage if there's not enough septum left. Now, if I go in there and find that there's some septum there, great, that's gold. I can use that. But oftentimes, if it's really collapsed and they've had 1, 2, 3, or even 4 procedures previously, I will often need to harvest a bit of rib cartilage and use that for support of the nose. You kind of have to build the nose up again. That does take a lot longer. In fact, sometimes it can take an hour, more than an hour, just to open the nose. It's like operating through concrete. Sometimes I've even had my scissors snap as I'm dissecting through the nose because I use very delicate scissors. And if it's like concrete that you're cutting through, it can actually break instruments. So it's difficult. You want to get in there, and any junk that's in there, you need to actually clear up. It's like renovating a house. You can't build on a destroyed structure. So you actually have to remove any rubbish that's in there and then replace it with strong, good quality cartilage, and focus on what's needed. You may have a collapsed dorsum or a collapsed tip or a piggy nose, and you just have to address where the issue is. So the question is, will it be a longer recovery? In general, yes. But I've been surprised by some patients with revision rhinoplasties that have bounced back quicker than some of my primary rhinoplasties. I think what's important is understanding what the procedures entail, knowing what to expect, and being prepared for that recovery. Being positive, following my instruction, close follow-up, and also following all the taping, scar therapy, and having a positive attitude, plenty of sleep, hydration, all these things help. Antibiotic creams, antibiotic tablets, making sure you take all the medications. So recovery is a bit longer. And it is absolutely what you've said. It is because there's a lot of scar tissue. When you're adding scar on to scar tissue, you tend to get more scar. And there's also a phenomena that can occur with the skin, because the more trauma you inflict her with further and further surgery, the more shrinkage and thinning of that skin occurs. And sometimes you actually have to add a little bit of thickness to that skin so that what's underneath it is not visible on the outside. Okay. Someone's asked, where does the cartilage come from? In primary rhinoplasties, with first-time rhinoplasty, someone who hasn't had their nose operated on, always the septum. The septum is the central cartilage that comes from just off the bone, comes down to close to the tip. In most patients, especially Caucasian patients, there's plenty of septum. That's all we need to support the nose, to build the nose, to make sure the airway is clear, to straighten the nose. So septal cartilage is mostly what we need. I almost never need to go to the rib or the ear for primary rhinoplasty in a Caucasian patient. In an Asian patient, that's a bit different, because in Asian patients, your septum is very small. So instead of being that big, it might be that big only. And because Asian noses are a little bit flimsier, they need a little bit more support. And so to build up the tip, or to give a little bit more lengthening, I may need to go to the back of the ear and harvest a bit of cartilage there to give support to the nose and to build up the tip. If an Asian patient wanted more dorsum, then I may need to go to the rib to take some more cartilage there. In revision rhinoplasty, if there is enough septal cartilage there, if that's not been touched, if the previous surgeon's gone in but they've left the septum alone, hallelujah. That's the best news, because then I can use the septum to build up the nose and to fix the nose. But in the majority of cases, the septum's already been touched, been played with, been taken out, been destroyed. So that doesn't leave much choice. If I only need a little bit of cartilage, take from the ear. But if I do need strong support, then I don't hesitate to go to the rib. So there are the three sources of cartilage grafts. The septum is my number one best source. If I need a little bit more, take it from the back of the ear. Or if I need a lot, then we go to the rib. Sometimes with the rib, we use it to build up the bridge as well. And sometimes we apply a technique called dice cartilage, where we chop it up really finely, almost like dicing up garlic. And then we can wrap that up in fascia and put it into the dorsum to build up the dorsum if that has collapsed. Some people may have heard of a graft called a composite graft or composite graft. That's often used to fix alar retraction. If someone's nose is hiked up like that because previous surgery has taken out too much cartilage, then you may need to pull that down and take a little bit of cartilage, including skin, to put into the deficit. So that's called a composite graft. Okay. Thank you for the question, Brie. Would nose tip refinement or a full rhinoplasty work for the bulbous nose? What would be better? Are they similar in price? Price for rhinoplasty depends on what we have to do and the extent of the rhinoplasty and the complexity of rhinoplasty. Without seeing a picture, it's really hard to know. I would have to say, though, that most tip work involves more than just the tip, because you have to balance up the rest of the nose as well. However, in the rare circumstance where it is just the bulbosity of the tip that needs fixing up, that is just a tip rhinoplasty, which would be less extensive, and therefore the cost would reflect that. You would need to refine the tip, but in almost all circumstances, you need to support the tip as well, and that will involve taking a little bit of cartilage, mostly from the septum, to support the tip. Now, sometimes people have a bulbous nose, and they also have a little bit of a hump or a prominent dorsum, but they go hand in hand. So if you refine the tip, it may then reveal a slightly more prominent dorsum. So you may then have to address that. So these are the little things, nuances that are important during my assessment. Sometimes I pick things up and then show patients and they never realize that. A classic example is someone who comes in with a droopy tip, pointy, hooked nose, and they say, I've got a bump, I've got this hump, and that's all I want taken off. Now, I'll tell that patient, if I take off that hump alone, your tip's going to fall even more. The problem in those patients is not just the hump, it's the tip that's dropped down because of a lack of support, and it's hooked and it's pointing downwards, and every time they smile, it dips down even more. In those patients, if you purely take the hump down, it's going to be a disaster because that tip, all it's hanging on is that hump. If you take the hump down, it's going to drop even more. So when I pull the tip up for those patients, they actually realize that the hump is not as big as what they thought. It's just because the tip's dropped and the hump looks relatively much bigger. But if you support the tip up, rotate it up, support it with a graft, it'll actually reduce the amount of hump that you have to remove. So it's all about relations of the different components of the nose, and making sure when I assess a patient, I know where the issue is and not necessarily where the patient's perspective is. Okay, welcome Penny and Jessica. Oh, Penny says, I saw you last Thursday regarding my bulbous nose. Hello. Jessica has asked, for ladies who haven't had children yet. Oh, here's a question on breast augmentation. Okay, I'm happy to answer that. For ladies who haven't had children yet and want a breast augmentation, do you recommend they wait? Do you find women coming back needing revision due to changing? Okay, classic question asked by a lot of women. It depends on where you're at mentally and psychologically in terms of when you want to have your breast augmentation. You shouldn't really let childbirth, childbearing, motherhood, because for a lot of women, they have kids and it's a long time before they have their breast augmentation again. And many women will say to me, you know, they were planning on having kids first before they have the breast augmentation, but then they end up trying for a long time and then regretting not having their breast augmentation earlier. So you should have breast augmentation when you're ready and when your desires for a nicer breast shape and volume comes. And sure, after you've had breast augmentation and you've had kids, your breasts may change, but they're going to change anyway. So, you know, if you have a little bit of deflation, a little bit of droopiness, you may need a lift. So it doesn't really matter in that sense, because if you have breast augmentation, you get a bit of droopiness, you might just need a lift to reposition the nipple, remove some loose tissue. But if you already had kids and you have some droopiness, you're going to need an implant and a lift anyway. So in that sense, it probably doesn't really matter. So I think it's really for if you're planning to have kids, but not sure when, I think you should put that aside and just think about yourself and how you feel about your own body and when you'd like to have the breast augmentation. Hope that answers your question, Jessica. Okay. Oh, Siobhan, hello. Thank you very much for your comment. You're a great patient, and it was a pleasure to help out. Thank you. I shall move on to another question. Okay, here's a question that says, I've heard of patients not being happy with their nose after surgery and the surgeon not caring that the patient isn't happy. Wow. Do you do revisions and under what circumstances? Okay. Patient satisfaction should be every surgeon's primary goal. Now the only exception to that is if there is truly unrealistic expectations and unachievable goals. Hello, Justine. So I think that's a pretty strong statement. You know, if patients are not happy about their nose, that's my primary goal is to make sure that, number one, the patient gets a good result, and number two, that they're really happy with their result. think that's the most important thing. You can have a result where I may not be 100% happy because it's not perfect. There's little things that I can see here or there which may not be perfect. But if the patient's 120% happy with the result, then I'm happy with that. Because sometimes as surgeons, we can pursue the goal way beyond what the patient expects. And that's not a bad thing. But I think our final goal should still always be having happy patients. Now, question, do I do revisions? Yes, I do. Under what circumstances? Well, it depends, you know, what you're not happy about. I think, yeah, the statement of saying surgeons not caring that the patient isn't happy, well, I think, you know, as a surgeon, we all want our patients to be happy. I think that's what makes us happy and what makes us continue doing what we're doing. Okay, someone's asked a question here about brow lifts. Is it cheaper to have in-practice procedures such as brow lifts because you don't have hospital stay? Is it safe? Do you have an anaesthetist? Do you go fully under? How does it work? So I'll probably classify the two trending procedures these days that's done in your office. I'll talk about both of them. One's the direct brow lift and one's a lip lift. I'll start with, because the question is relating to brow lifts. When the brow drops, whether that be because of age or because of some other conditions, premature drop of the eyebrows, there are a few ways in which we can elevate the eyebrow. I've done them all. There's the traditional classic way, which is still the gold standard, of zipping from one side to the other. That's called an open forehead lift or an open brow lift. Now, I've done plenty of those, but they were many years ago, and they work really well, but you end up with a scar that goes from one side to the other in the hair, which hides very well. Now, that is like a peel off the forehead, lift up, remove the excess skin. That's a very extensive procedure. That's called an open brow lift, and that's quite extensive, and a lot of patients find that quite scary. I do too, for the patient. But that's very effective. Not many patients have that these days because it just sounds too much. Then there's the limited incision or temporal brow lift, where you make an incision here. Now, that would not work very well on me because you can see my forehead actually goes up pretty high here. So even if I make a cut up here, you can still see it. If you have a low forehead, then that may be applicable. But that's usually done at least under a sedation or a twilight anesthetic or a full general anesthesia. There's endoscopic. Now, I personally have done endoscopic brow lifts, but that's sort of gone out of fashion a little bit because we tend to see a lot of recurrence. There are a few surgeons who are still very good at endoscopic, but I've stopped doing endoscopic brow lifts because I think in my hands, there's a real high recurrence rate. These days, there's a way of doing a brow lift whereby we just excise skin above the brow itself. And that can be done under a local anesthesia. I've done that for a number of years now, and I sort of slowed down a little bit and have picked up a lot more of it recently. The thing that sort of deterred me from a direct brow lift previously was because I thought, maybe the scar is quite visible right there. But I've actually found if you apply the right techniques in terms of how you cut the skin, how you sew the skin, how you manage the scar can actually be quite invisible in that area because it's just above the eyebrow. Now, if you have a temporal brow lift where you make a cut there and you have a bad scar, that can be quite visible as well. The reason why I like doing a direct brow lift is not only because it can be done under a local anesthesia in your office, so you save the risks of an anesthesia, a general anesthesia or a twilight anesthesia, plus you save costs of anaesthetist as well as hospital admission. They're some of the advantages, but the biggest advantage for me is the effect that you can have in lifting the brow in the shape and the direction that you want. Because if you just play with the eyebrow right there, you can move it a lot more when you place your finger just above the brow there. Whereas if you go further up, the further up you go, the less pull and effect you have. So if you're going to go from your temple area, go all the way down here, especially if you have a very long forehead like me, the effect of pulling it from there to move the brow is a lot less than the effects here. So I can get a lot more control by doing a direct brow lift. And patients like that because they come into the office, local anesthetic injection, we take the amount of skin off there, we lift off the brow, then we treat the scar healing process as a process, and we try to get that scar as optimal as possible. And after a certain period of time, it's actually, I'm amazed at how invisible the scars become. And so, you know, if you get a good scar there, it's much better than getting a bad scar there, if that makes sense. I would still do a temporal brow lift in some patients with a really low forehead, and the distance that I have to go from there to there is very short, so the effects is still quite good. But, you know, if patients don't want to go into hospital, they don't want to go under a full general anesthesia, then the direct brow lift is quite a good operation. Now, lip lifts. That's a good operation, a lip lift. It's more of a recent phenomena because traditionally people have enhanced the lower lip with fillers alone, and that's still very applicable. But one thing we've noticed about facial balance and youthfulness is the length of the upper lip in relation to the length of the chin as well as the rest of the face. If you observe older people, 60s, 70s, 80s, you'll notice that the lower lip will start to get longer and longer. And the longer your upper lip gets, the thinner this appears. And when you smile, you don't see as much teeth. And even when you're resting, you don't see as much upper teeth show. When the upper lip is slightly shorter, it does give an appearance of youthfulness. And with a little bit of teeth show, that again adds to youthfulness as well. And when you do a lip lift, you not only reduce the length of the upper lip to make it more proportional in ratio compared to your lower lip, which is the chin area here, you also plump up the upper lip, and you also increase a little bit of upper teeth show. And so all those things add up to a much more attractive lower face or perioral area. Now the lip lift, I don't really point out to patients. Most patients that I do lip lifts with will come in asking for a lip lift. I will sometimes point it out with my facelift patients because if they need jowls and neck done, oftentimes their lips quite long as well, and it's not much more to add to it. It can be done quite easily under a local anesthetic, although if the patient was having another procedure done, such as breast work or abdominal work or facial work, then they're obviously under a general anesthesia already, and the lip lift can be added onto that. But a lip lift is essentially removing a slither of skin just underneath the nose here, and then lifting that remaining upper lip skin to meet the base of the nose. Again, the biggest issue with a lip lift for many years in my practice has been the scarring, because I was always worried about a visible scar in that area. The risk of bad scarring is probably higher in the Asian population as well as dark skin individuals. They just have worse risk of scarring overall, period. But for the majority of patients, the scar there actually heals up very well, especially if you look after it, moisturize it, massage it, apply silicone ointments to it, careful stitching, internal stitches to hold the tension, very fine external stitches that come out early. And if you manage the scar, it will take some time, but they usually fade off very well. Now, what's the ideal length? That's kind of an eyeball thing, right? I take a 2-second look at somebody and I can see whether their lip ratio is long or short or perfect. Now, what do you make the lip? What's the goal? How long should the length between there and there? It depends on their facial shape. For example, do they have a long face? Do they have a circular face? Do they have a round face? And what are they aiming for? Some patients will ask for a slightly shorter lip, slightly poutier lip. So I have to take that into account as well. You know, if you measure your lip distance from the base of your nose to about your upper lip area, 11, 12, 13 millimeters should be quite normal. If it's longer than that, then I usually consider that long, and I try to aim for that 12, 13 millimeters, although some patients do ask for it to be a little bit shorter than that. It can be easily done under local anesthesia in the office, and would, you know, be less than an hour procedure. Same with a direct brow lift. That's a wrap for direct brow lift and lip lifts. I've spoken about what they can achieve and what the surgeries entail. If anyone has any questions, please feel free to comment, and I'll try my best to. Okay, here's a question. Hello, Judith. Does the lip lift take away the lines above the lip as well? So you're talking about wrinkle lines along here? No, it doesn't. Unfortunately, it doesn't, and there's not many things that can remove that. I do know of some practitioners who put little bits of fillers into the kind of dips between the wrinkles, and they can sort of stiffen up. And I've asked so many of my colleagues, so many senior surgeons and mentors of mine, is there any way we can fix the wrinkles here? The only sort of solution that I think makes sense is fillers, just tiny amounts to stiffen up the upper lip. But no, if you do a lip lift, it will just reduce the length of the lip, increase the show of the red lip, which is the poutiness of the lip, and increase the teeth show a little bit, but it does not remove the wrinkles that's pre-existing. So it's still going to be there. Hope that answers the question. Does anybody else have any other questions pertaining to lip lifts or brow lifts? Direct brow lifts. I'm not going to talk too much about temporal brow lifts or open brow lifts, limited incision brow lifts. I'm just going to talk about the direct brow lift, which is done in the office. Now, a lot of people have asked, does this only apply to older patients where they already have wrinkles? And now if they're men or older patients who've already got a lot of wrinkles in the forehead, it's the perfect operation because you're not worried about adding an extra scar just above the brow where it will probably fade away and be less visible than the pre-existing wrinkles. But it applies to younger patients as well because, you know, I've seen some horrible scars up here from brow lifts. If you try to pull really hard in the temporal area to get a bit of lift in the brow and this is tight, that can result in a really bad scar. I'd rather have a nicer scar here than a bad scar up here. Okay, here's a question from someone who has asked, what questions should I ask a rhinoplasty surgeon to make sure he knows what I want? What questions should I ask at consultation? All right. In my rhinoplasty consultations, when the patient walks in, they sit down, I say hi, general introductions, then this is a question I will ask the patient, you. I say, what is it about your nose that you don't like? What bothers you about your nose? Tell me everything about your nose that you don't like, and be specific. I cannot help the patient if the patient cannot describe to me what they don't like about the nose. It's not helpful or good enough just to say, I just don't like my nose. Help me fix my nose up. Because if you can't be specific about it, then it's really hard for me to help. I will guide the patient in my assessment because a lot of patients come in and they hate the nose so much they don't know where to start. You just say, this, I just don't want this. So I always start from the top. What do you think about your bridge? Okay, so you've got a hump. There we go. We've identified one thing. What do you think about your tip? Is it droopy? Is it bulbous? Is it pointy? Is it hooked? Let me have a look. Is it bouncy? Is it lacking support? Tell me about your airway. Do you have any breathing issues? We take it from there. What do you think about your alar base? Do you think it's too wide? Do you think it's too narrow? And then once I sort of outline the issues that the patients are not happy with, then I can formulate a plan to address each of those issues. That's what happens in my rhinoplasty consultations. I can do simulations to show the patient I can do drawings to show the patient the techniques that I apply. I don't go too much into technical details unless the patient asks for it, or unless it's a revision rhinoplasty. But I try to make it simple and easy for the patients to understand. I don't try to have too many goals, because the more goals you have in rhinoplasty, it starts to complicate things. And remember, a lot of the revisional rhinoplastic patients that I see, the problems has arisen because too much has been done. Too much cartilage has been altered with, too much tip has been cut out, too much hump has been taken out. When you do too much, when it's not absolutely necessary, you can actually incur issues which need fixing. Now, questions that you should ask your surgeon is, well, all right, so you should ask your surgeons, how many rhinoplasties do they do? Are they experienced in rhinoplasty? Because rhinoplasty is not for beginners. It's probably considered the most technically challenging of all plastic surgical procedures. Now, in terms of time, it probably takes, say, for example, 3 times as long as a breast augmentation procedure. It's quite complex because there's many aspects of skin, soft tissue coverage, cartilage, bone, functional and aesthetic concerns, and it's in the middle of your face, so you can't really hide the results there. So you should actually just check to make sure that your surgeon is experienced in rhinoplasty. A patient asks me, how many do I do? Probably at least 2, sometimes 3 a week. You need to. It's also changing rhinoplasty, how we do rhinoplasty. It's becoming less destructive and more constructive. So these days, for example, we used to use chisels to chip the bone, to move the bone, crack the bone, to move them in. But these days, I tend to use an ultrasonic saw called piezo, or piezo ultrasonic surgery saw. And these tools allow me to cut the bone very precisely, exactly where I want, without harming the soft tissue. So there's less swelling, less bruising, instead of using a chisel and banging, where you can have unpredictable cracks in the bone. And so we're just trying to make the procedure more predictable so that we can have the outcome being more predictable as well. Any other questions you should ask your surgeon? Ask them to show you befores and afters, realistic ones, not just the best results, but someone who's like them, because patients may come in and they say, show me some befores and afters, and I say, well, I'm not going to show you my best result. I'll just show you someone that I think looks kind of like you, and we want to achieve results similar to what you want to achieve as well. So I think that's important. They're the questions that you should ask. Oh, hello, Penny. Penny has asked me, what is it about your nose that you don't like? Never thought too much about that one. I have a breathing issue though. I've stuck a camera up into my nose and found that I've got a slightly deviated septum. I don't think I want to get it fixed because it's not that bad. When it's allergy season, like right now, it becomes blocked up occasionally, but it's not enough for me to have an operation on it. What is it about my nose I don't like? It's not a Brad Pitt nose, but I don't think a Brad Pitt nose would fit my face either. So I guess I'm pretty happy with my nose. I guess this could come in a little bit. What do you think? Does that look good? Nah, I think I'll stick with my nose. Any other questions? Post-operative recovery. Is it painful? Post-operative recovery. A lot of people are scared about the post-op visit because they've seen YouTube videos about people coming back for their first visit and then someone pulling out this gauze that's a mile long and it really feels like their brain's coming out. I don't use packing in the nose anymore. I use a silicone splint, which is about 8 centimeters, 7 centimeters long. It's silicone, so it slides out. And that's all I use on the inside of the nose. I don't see any need for packing. Packing used to be used to provide support, just to make sure the nose doesn't fall. But these days, if you can stabilize your nose during the operation, there's no need for packing. So when patients come back, these are the things that happen. The external splint comes off, that just pulls off. The taping that I've got comes off. The 2 internal splints come out, and about 4 stitches from here come out. The rest of the stitches are inside and they'll dissolve on their own. Any other questions about rhinoplasty that anybody has? I think I've talked about the skin quality already. That's one of the most important things when it comes to healing, the result, how we approach the surgery, and the post-operative care as well. One of the most challenging patients is the patient who's desiring rhinoplasty, but they have very, very thick skin. And this is the kind of skin that you can see pores in. You feel it and it's spongy. And these kind of skin, after rhinoplasty, they really swell up. And so sometimes I even have to thin the skin down from the inside so as to reduce that kind of internal scarring. The patient has asked previously, do you ever inject steroids into the nose post-operatively to reduce scarring? Sometimes I do. If I feel that there's a bit of scar buildup, I will inject a bit of steroid to try to reduce the scar bulging. My biggest fear in terms of potential post-operative complications is not so much the scar that's here. The scar here, that will always heal up perfectly. What bothers me more, and the reason why I see my patients at 1 week, 3 weeks, 6 weeks quite regularly, is the internal healing and the internal scarring. Even though the nose is a central object, it has a left and a right side. And so you can have asymmetrical healing. You can have one side heal up differently to the other, and also different amounts of scarring as well. And so I have to keep a very close eye on that. And I'll get the patients to tape accordingly and to massage the nose accordingly so we can guide the nose in its healing to be perfectly straight and healing the way we want to heal. Tracy has asked, do you do revisions on any other surgery, such as LBL? Just remind me what LBL is again, if you can. Would you be able to elaborate on what LBL is, please? I probably should know, but it's been a long day. Oh, lower eye lift. Okay. Okay, so lower blepharoplasty. Lower blepharoplasty is something that I don't do a lot of anymore, but I've done plenty of it, and I know all about lower eyelids. Lower eyelids is a total different ballgame compared to upper eyelids. There's a whole lot more involved in lower eyelids. Traditionally, eye bags in the lower eyelid have been removed. These days, we don't remove the eye bags anymore. Some of my best results in lower blepharoplasty have been where I haven't removed a single bit of fat, but I've actually just redraped the fat. So you often have a groove here and the eye bags above it. You have to break through that groove and move the fat downwards in order to smooth out that area. And you can remove some skin as well, but oftentimes, once you've redraped that fat, not too much skin needs to be removed. I don't think lower eyelids can be done under a local anesthesia. There's just too much involved there. The complication risks in the lower eyelid surgery is much higher as well. And upper eyelid lifts, which is an upper blepharoplasty, where you remove the excess skin, remove some fat, the complication risks there is much lower compared to a lower eyelid surgery, whereby there's a whole, if you get scarring that's excessive, you can actually have ectropion or dragging down of the lower eyelids. So, oftentimes when you do a lower eyelid surgery, you actually have to tighten up the corner of the eye to support the lower eyelids, because swelling and scarring can actually cause that lower eyelid to come down. It's not an operation that can be done under general anesthesia, in my view, and I don't think many surgeons actually do this procedure under a local anesthetic. It has to be done under a general anesthetic, I think. Oh, okay. Okay, someone here has mentioned lower eye lift, but lower body lift. Okay, gotcha. Lower body lift. Circumferential abdominoplasty. Well, that certainly can't be done under a local anesthetic. But we can talk about that. So when a patient comes in after they've had weight loss or had lots of kids, and they've got a lot of looseness in the belly area, but that looseness extends to the side and the back, and this happens in a lot of patients with massive weight loss, you need to consider a belt lipectomy, otherwise known as a circumferential lipectomy, otherwise known as a lower body lift. It's a great operation. When someone comes in with loose tummy skin, if they can get away with just an abdominoplasty or a tummy tuck, and they're not too worried about the sides and the back, then I will offer them a tummy tuck. If a patient comes in with mostly front, lower abdominal laxity with a little bit of side fullness, what I can do is an abdominoplasty with liposuction along the sides to get it in a little bit to improve the waist so that they don't have the two dog ears and the bulges on the side there. But if someone obviously has lower abdominal skin that goes all the way around to the side, where you can really just, pull off a lot of skin on the side, love handle area, and the back, then they will really benefit from a circumferential lipectomy, where you remove the front, the side, and the back, almost like ring barking. It's a bigger procedure, obviously, and it involves a hospital stay, maybe about 2 nights or so, but the results can be quite spectacular. And in patients who have excess skin in the lower abdominal area, the sides and the back, I will actually recommend that and not an abdominoplasty, because I know that if I only do an abdominoplasty, I won't be happy and the patient may not be happy as well, because there's going to be still excess skin on the sides and the back, and I'd rather complete it by doing the circumferential. Hope that helps. Okay, someone has said here, hello, Jean, do you perform the S-lift and under twilight sedation? So I think by S-lift, what you're talking about there is a facelift. I don't perform, well, S-lift is a fancy name for the incision that you make, which is in the shape of an S that goes something like this. It's essentially a facelift incision. I think the term S-lift has been used as a marketing tool, just like laser upper blepharoplasty or laser eyelid lift, where you're just using the laser to cut the skin instead of using a knife. I think an S-lift is just the shape of the incision, which is a facelift incision. For me, I've tried all sorts of different facelift techniques, short scar, minimal dissection, and extensive facelift. I think I can't get a really good result without doing an extensive dissection. When I do a facelift, it's usually pertaining to a lower facelift where we're fixing the jowls as well as the neck laxity. And more often than not, I will actually make a cut underneath the neck, tighten up your muscle so that we're tightening it from the center as well as tightening it from the side there. So for me, I do a fairly extensive skin dissection, and then we have to do something to this layer called your SMAS, S-M-A-S, which is the ligamentous layer underneath your skin. And that's when you would just lift up the inside layer and then the excess skin can be removed. So that's a fairly extensive procedure. And for me, I only do that under general anesthesia. I have worked previously overseas with my mentors where we have done this procedure under twilight anesthesia. It can be done, that is true. You can do big procedures under twilight, but just in my practice, my preference is to have it done under a full general anesthetic, but I do know that a facelift can be done under twilight anesthetic quite safely and quite successfully. My preference is for a general anesthesia. And so you see, S-lift, different surgeons have different extent of dissection or extent of the surgery when they're talking about an S-lift. I think what's important is that the inside layer gets tightened up as well, and you're not relying on just stretching and pulling off the skin. If there's definitely some neck laxity, I think you need to tighten up both from the center and from the sides as well. Someone's just reminding me LVL is a low body lift. Any other questions? Talked about lower body lifts. We've even talked a little bit about breast augmentation, rhinoplasty, brow lift, upper eyelid, great procedure. I've tried all sorts of techniques. These days, we tend to just remove mostly skin and a little bit of fat from the inside. Gone are the days where we just strip the eye of its fat. We used to think that was a good thing, and we remove all the fat pads from the upper eyelids, and the patients ended up looking quite sunken in. These days, we preserve fat and only remove a little bit of the fat that's obviously bulging out, and mostly skin, and we tend to preserve the muscle as well. So things are changing. Techniques are changing. They're evolving. We are being less destructive these days and more constructive, being more supportive in terms of structure. We've talked a bit about facelift, setback otoplasties. It's a great operation for patients with prominent ears. Mine's a little bit prominent, but it's not too bad. Again, that's one of the operations that has a very quick recovery, and patient satisfaction is usually very good for that. Okay. That's all right, Tracy. Sorry for the confusion. Referring to belt-like pectomy revision due to poor buttock outcome. Completely flat buttock following belt-like pectomy. Thank you for the information. Low eyelid, very informative. That's my pleasure. Yeah, one of the issues with belt-like pectomy is that it can result in a very flat buttock. So I guess one way around that is to preserve a lot of the tissue and remove most of the skin, not too much of the fat. There are techniques whereby you would almost leave an island of fat just over the buttock and pull the skin over it so that you're still preserving that fullness in the buttock. Now, failing that, one can consider some fat grafting to the buttock, but you got to be careful with fat grafting because fat grafting, it's currently trendy. You know, I had a case yesterday of breast revision where I did some fat grafting as an adjunct, but you got to be careful. Too much fat grafting does have its risks, and in the buttock, there are risks related to fat embolism and also necrosis or death of the fat if you inject too much fat, and you can end up with lumpiness there. So it depends in terms of a flat buttock. Why is it flat, and what can be done? It really depends on patient to patient. Fat grafting is an option, and I think if you already had a belt lipectomy, your options are quite limited because if there's stuff that's already been removed, then you kind of can't preserve anything further. You have to add things to it, and maybe fat grafting is one option there. Kat, hello, welcome. Do you perform reconstructive surgery after weight loss? Yes, plenty of it. What is involved for a male that needs augmentation of the breast area? So for men after weight loss, I think that's what you're relating to. They don't really need augmentation. Most of the time it's because they have a lot of loose skin in the chest area and the nipples have dropped down because of that, because when they were overweight, they had breasts. And when they lose that weight, it becomes almost like saggy breasts. And so they actually need to have a lot of that tissue removed and have the nipple repositioned. Nipple repositioning can be done two ways. You can have free nipple grafting. The risk of that is that the nipple may not survive. Or you can have it connected on the pedicle and just moved upwards. That has its advantages and disadvantages, and it really depends on the patient. You're welcome, Tracy. I hope, Kat, that answers your question, because I don't think men, after they've had weight loss, really needs augmentation to the breast area. Women do. Women who have had massive weight loss, they would have lost all the volume in the breast and saggy, empty breasts. And so these patients will need volume restoration as well as reshaping. So they'll more often than not need an implant together with a breast lift or a mastopexy. That can be a great operation to treat both the shape and the volume loss. I hope that answers the question, because the question did ask about men needing augmentation of the breast area, but I think in most men they actually need tissue removed and flattened so that they can actually show a lot more of their pec muscle. So I actually need, yeah, you're right. Yeah, you got it, Kat. Any other questions about anything else pertaining to plastic surgery? I'm yours for tonight. If you have any questions, this office, just pretend you're sitting in front of me. What do I do mostly? Probably noses and breasts and body, especially now with a lot more weight loss surgery being done. I'm seeing a lot more patients who have a lot of loose skin after massive weight loss. And massive weight loss surgery is a process, it's a journey. There's no just one operation that will fix everything. You have to consider safety in these operations. You can't do too many things at the same time. You hit a home run with one operation, then you tackle the next. So it's a bit of a journey, and patients need to be aware of that in the weight loss journey, that it's not a one-stop shop and have one thing done and that's it. Some patients will need revisions, because when you have loose skin and lax skin, the way it heals, there may be some recurrences, and so little touch-ups may be necessary. What else am I seeing a lot of these days? I'm seeing a lot more revisional breast surgery as well. Patients need to be aware of the fact that breast implant surgery is not a forever kind of surgery. They're not lifetime devices. Things can occur. Things can rupture, capsule contracture can occur. Malposition can occur. So if you have any concerns there, do see your plastic surgeons. There's a myriad of, it's a whole new world when it comes to breast revisional surgery. Just like revisional rhinoplasty. I love revisional rhinoplasty because it kind of brings out the real reconstructive toolbox. I really have to bring out every tool in a reconstructive rhinoplasty, revisional rhinoplasty, because it's a small area that we're working with. It's an area that's on show to the whole world, and you're trying to fix both the functional as well as the cosmetic aspect. And when it comes to the nose, both are equally as important. I don't see the cosmetic as being trumping the functional or vice versa. I think I've seen a lot of patients who come in to see me for revisional rhinoplasty where their nose actually looks okay, but they can't breathe. And life sucks when you can't get enough oxygen in. So for those patients, I have to then attend to the functional aspects. And same thing goes, even in my own patients, sometimes I've learned from patients whereby I've improved their function out of this world. They can breathe so well, but the nose might be a little bit bigger, a little bit chunkier than what I was hoping for. So I've had to go back and kind of shave things down a little bit and touch things up a little bit. So I think in rhinoplasty, any rhinoplasty, whether it's revisional or primary, you have to consider both aspects. Okay, how long between operations would you recommend for excess skin? So you're talking about massive weight loss surgery whereby you may need a tummy tuck or a bell lipectomy and a thigh lift and a brachioplasty and the breast reduction or a lift, implants with a lift. So the general consensus there, how long do you wait between surgeries? It's when you've healed up, you know. How long you can heal? Some patients heal quicker than others. Anytime between 3 to 6 months, especially if it's a different area, that's going to be okay. You should be healed pretty well by that stage, enough so that you can have your other further surgery whilst you're not still recovering from the previous surgery. So in general, I'd say probably about 3 to 6 months between surgeries. But you also have to consider, you know, time off work, family arrangements, and all that as well. And so, you know, when I see patients during a recovery, we would often be discussing their next procedure and planning that. Any other questions? Any other questions? What else is... I think you guys have had other live chats about breast already. I think that's been kind of overdone. Chin. I do a lot of chin surgery, and that's important. I think chin is one of the most underrated areas of the face. A lot of people come and see me, they say, I have a big nose. I said, no, you don't. You have a small chin and maybe a big nose, because it's all about a balancing act. If you have a sizable nose and a small chin, it's going to make your nose look even bigger. This is particularly true on a profile view. You know, if your chin doesn't balance up your nose, then you look kind of top heavy. And I've done a lot of cases whereby I've done a reduction rhinoplasty and at the same time I've enhanced someone's chin. Two ways of doing a chin augmentation. The first is a genioplasty and the second is an implant. So with a genioplasty, we cut through that bone, we move it forward, we lock it in place with titanium screws and plates. With an implant, you pop an implant like that, but I don't just put it there because it can move. I will screw it in as well. So my preference is generally a genioplasty because I think it's a much more natural procedure. You're actually keeping everything just as the patient is, but you're just enhancing it. Implants can have their issues. They can get infected even years down the track. They can move. And I've done a lot of cases where I've removed a patient's chin implant and done a genioplasty on them, and they've had really good results. But it's important. If you're thinking about rhinoplasty, just make sure you look at your profile view and make sure that your chin's in tune with your nose as well. What's the most common presentation for rhinoplasty that I see in my practice? Being in, you know, we're in Australia. Most of my patients are Caucasian patients. Most patients are young patients, although, you know, even last year I think I did about 3 or 4 patients who were over 60 years of age. That's still fine. There's just a few issues when you're older that I have to let patients know about, such as the skin and how it reacts after rhinoplasty may not sort of twang back as tightly as someone that's a bit younger and has thicker skin, stronger skin. So the most common presentation that I see in my rhinoplasty practice, someone who comes in with a hump, a big tip, and a droopy tip that's unsupported. By far, that's the most common presentation. So the solution there is to do a hump reduction, tip refinement, tip support with a cartilage graft, tip rotation, and oftentimes tip deprojection to reduce how far it sticks out as well. So in doing so, you end up with a straight nose, a finer tip, a stronger tip that doesn't move, especially when you're smiling, it doesn't dip down, and a more stable nose with a stable airway. Any questions, anybody? Okay, well, Trish, are there any other questions that I haven't covered? I'll just quickly check. No, that's all. That's all. I hope it has been very helpful for those who have attended tonight's session. If you have any other questions, feel free to email my office. You can send along photographs for an assessment if you want. Yeah, never be afraid to ask questions. There's no such thing as a silly question. Oh, I've got a few questions here. Where are the incisions made for areolar reduction? Do you do lift, implant, and areolar reduction in one surgery? Okay. So whenever we reduce the areola, we always make the incision on the areola edge itself, and we use a little, almost like a cookie cutter, to mark out where our new areola is. So how big we want our new areola. And it's usually around 4 centimeters, sometimes 4.4 centimeters, depending on how big the breast is. But around 4 centimeters is the kind of guide. And so you have the areola, say for example, is there. You mark out where you want your areola to be with the nipple in the middle. You mark out what's on the outside of the current areola, and you remove all that skin in between. So when you do a lift with implants and areola reduction, yes, you do all that together at the same time. So that's called an implant with a lift, or an augmentation mastopexy, or a lift with an implant. Now, the process of doing that procedure is I put the implant in first, and that's usually in a submuscular dual plane position. And you can use textured implants or smooth implants, and some members may know there's a lot of controversies about that at the moment with ALCL and breast implant illness. But you put the implant in first, that's my way of doing it. Then you lift up the nipple, remove the excess skin, and that's your lift component. Now, there are many surgeons who would do that procedure in 2 stages. That is, they would do the lift first to get the nipple in the right position to remove the excess tissue. Then they'll come back 6 months after and put the implant in. That's good as well. I've done plenty of that. It probably is a little bit more predictable in terms of the outcome, but I think I've got a pretty down pat in terms of the outcome I'm happy with doing in 1 stage, because it's just, for many patients, just too hard to have 2 operations. The only proviso I would say, if we're doing a 1-stage lift with implant, is that you can't go too big with the implant, because it's really 2 opposing forces. Your lift is trying to do this to your breast, and the implant's trying to do this to your breast. So you've got to have a compromise there. So it can't be a huge implant. You got to have a moderate projection, not too big. You know, anything between 250 to 350s. I've done 400 as well, but nothing in the over 400 range. It's just too risky in terms of wound healing. But that's Lacan. That's the procedure there in terms of areola reduction, lift, implants, areola reduction in 1 surgery. Is it more difficult to do a revision of another surgeon's work? It depends. Sometimes you have no idea what's been done, so it can be a little bit more difficult, especially with rhinoplasties, because if you're going into unguided territory, you're not sure whether the septum's there, you're not sure what's happened, and you often come across surprises. Great example. Recently, I had a breast revision case, 3rd time surgery, removal, replace capsulectomy, removal, replace capsulectomy again, and this time it was removal, replace with me. One side, muscle was intact, did the capsulectomy, removed the implant, replaced it, did some fat grafting, did some tightening of the pocket on one side. Got to the other side, there was no muscle there. Pec muscle completely gone. Where is it? I have no idea. So obviously in the previous surgery, the pec muscle was cut out during the capsulectomy. Sometimes you come across surprises like that, so it can be a little bit more difficult. Now, I think you're asking the question in relation to massive weight loss, had a circumferential belt and breast augmentation, then the breast lift and medial thigh lift. Medial thigh lift performed to try to supposedly lift the buttock, but unfortunately there was absolutely no change to the thigh buttock, just an unnecessary scar. Surgeon seemed lost as to where to go next. I think it's always good to get opinions. Sometimes revisional surgery can be very difficult, whether it's your own case or whether it's another surgeon's case. Get a few opinions, send your photos to surgeons, see what they think. If a surgeon is honest with you and say that they're not confident in being able to fix that, respect that. They're being honest with it. It's better I'm honest with my patients. If I think this is going to be difficult, I'm not sure if I can get what we want to achieve, and I will say to patients, no good promising them what can't be achieved. So I think it's important to get some opinions there. How long is your waiting list for a review? My office would probably have the answer to that. You're welcome, Trish. Bree, you're welcome. Tracy, you're most welcome. Lakin, great information. I thought it was only the lollipop cut, and I wasn't keen on the scar it would leave behind. Okay, so you're talking about breast lift with an implant. It depends on the degree of sagginess and excess skin. If there's not too much sagginess, you can lift the nipple up and have just an areola scar. If there's a little bit of skin laxity this way, you will need a around the nipple and down scar. If there's a lot of laxity in both directions, for example, if you can close and open the breast this way and move things this way, then you cannot avoid a scar around the nipple, down, and across the breast crease. You know, I always counsel patients about this scarring because a lot of people are quite scared about scarring the breast. I will say that the scarring in the breast heals up very well, and after about 6 to 12 months, it is very faint. What's better, to have a bad shaped breast with no scars or scars with an awesome shaped breast? I think the latter. And I will tell my patients that scars will fade, but getting a good breast shape, good volume, and just nice breasts is what counts. Okay, so I think we're coming close to 1.5 hours now. I thank everybody who has joined me tonight for the Facebook live chat. I think we've talked about a lot of stuff. Hopefully I've answered some questions that people have had in relation to the topic for tonight, which is rhinoplasty, brow lift, as well as lip lift, but also answer some questions pertaining to massive weight loss as well as breast surgery. I think plastic surgery is like any surgery. You know, it comes with its own set of risks, and it is real surgery. And I think most of you understand that. And I think it's very important for patients to be very well informed of what plastic surgery can achieve and attain, and where the limitations are, and obviously the potential risks and complications. Now, what differentiates a well-trained surgeon and someone you should go to is not so much whether they know the steps to the surgery. It's whether they're experienced in the surgery and whether they pay attention to what the patient's desires are and develop a plan that will achieve that realistically. And also what differentiates, say, for example, a plastic surgeon from a cosmetic surgeon who hasn't had as much training is the ability to fix problems, all right? Because, you know, problems will arise, they're rare, but when complications arise, you want to be able to look after your patients to still get the best possible outcome, and whether that be through revisional surgery or just simply making sure that the patient's looked after if they have a complication, and doing whatever is necessary to get the best possible outcome despite that complication. Is there anyone with any final questions that they would like to ask? Otherwise, we might end the Facebook Live. Trish, if you want to give us the all clear to end, I will finish it there. Okay. Good chatting to you, everyone. See you around. Take care.